To share the impact that AI has had on COVID, we have Romy Hussain. Romy leads the centralized AI program for Johns Hopkins, and her work has been instrumental in helping their system treat COVID patients and in helping the state of Maryland respond appropriately to the pandemic. Romy's perspective is an interesting one, filled with hope for the benefit of AI in responding to a catastrophe, but also with caution due to the policymakers' less than data-driven decision-making approach. Please join me in welcoming Romy to the virtual stage.
Thank you so much for having me at AI for 2020. It's an honor and a privilege to be here with you today. The truth laid bare by the COVID-19 pandemic is that we're not only dealing with a public health emergency, but also a data science issue on a scale we haven't seen in my lifetime as well. To make good judgments about something that's inherently unknowable and rapidly changing as a pandemic, using the AI tools that we have available to us today, we need to make data collection systems that are as robust, as localized, and as timely as possible. This is one of the reasons that we at Hopkins took lessons from other industries, up to and including viewing Amazon package tracking tools, to design just such a system that has become synonymous with a global source of truth for COVID-19 tracking data. To make good decisions, you need good data. You need good predictions, rather. And to make good predictions, you need good data. But not just any data, the right data. Especially early on, widely reported case rates implied that cases were very low, when in reality, it's more likely that while hospitalized or detected cases were low, the fundamentals for infectious transmission were ever present. One of the reasons that reported cases is so bad as a metric is that there's a long lag between when someone is infected, when they develop symptoms, when they get tested, if they get tested at all, and then when those test results are reported. A projection by ICL estimates that actual infections range from 2x to 100x higher than the reported case rate. With a variation that wide, it's hard to learn from other countries' experiences. Prediction might help us, especially AI and machine learning predictions, control for some of those unknowns by predicting the pandemic's outcomes and spreading patterns based on those underlying fundamentals of the virus's transmissibility. What's important then isn't just collecting the right metrics, we also have to understand the countermeasures, such as testing, tracing, treatment, that are being enacted locally. If testing is increasing, the rate of growth of a disease can actually be overestimated. Similarly, if testing is stagnant or decreasing, the rate of growth can be underestimated. We saw this early on in the US. Two recent studies indicated that there's up to a 20-fold difference in case detection rates between countries doing the best job of testing and those doing the worst. The US falls somewhere in the middle of that spread. What this means is that, for example, in a country that has 1,000 reported cases of COVID, there could actually be 5,000 infected people, but in another country, there could be 100,000 infected. This trend is exacerbated along racial lines, socioeconomic lines, age brackets, as well as spatial proximity, just geographic access to testing sites. So the way we use the data that we have available to us to inform our predictions matters. So with all these challenges in getting at something approximating the truth, how do we glean enough insight to make good decisions as a health system or a municipality or even a state? This is where we turn to prediction. Data science enters the ring. It is a truth universally acknowledged that all models are wrong. Some models, however, are useful in the ways in which they're wrong. We need data science then to help us explore both the ways in which they're wrong and the ways in which they're useful. We also need data science to develop the predictions in the first place. The results of these models will inform the decisions that are made to combat the spread of the pandemic, so the stakes couldn't be higher. Now, one of the models that came to the fore during the early days of the White House press briefings was the IHME model. Here you see it on the left. On April 2nd, the death projection from this model was 90,000, but on April 7th, it was only 60,000. The model was characterized by tremendous volatility that varied by day and even time of day depending on when updates were made. The performance differential between it and more traditional pandemic models, such as the one on the right, lies in the way the model works. IHME starts with mortality rates in city overseas, fits it to something like a normal bell curve, and then attempts to situate the US on that curve. The death curves outside the US are assumed to explain and to describe the US also, without any attempt made to determine whether countermeasures, lockdowns, masking requirements, quarantines in the US are as effective as elsewhere. This method isn't particularly good for predicting the future. It's better suited for situating the current state within the context of the past. There are two widely accepted model types for predicting the course of infections. One is the SEIRD and one is the agent-based system. Now, the SEIRD has been around for a century. It's the interplay of 5 different disease states over time: susceptible, exposed, infected, recovered, presumed immune, and deceased. Lots of different flavors in this model. Some infectious diseases are modeled using only susceptible, infected, and susceptible. There's no assumption that the virus confers basic immunity, the common cold, for example. SEIRD is more appropriate for COVID. Agent-based modeling is a relatively new approach. It's composed of agents whose behavior is described using very simple rules, corresponding to things like spatial patterns, social characteristics, health conditions, as well as the underlying infectious fundamentals under which these agents interact to model out the transmission process. Now, both models are good at slightly different things. SEIRDs are useful for absolute accurate predictions. Agent-based models are better for modeling multiple scenarios to identify the relativity of results under different operating assumptions. They're also good for comparing the results of implementing various potential mitigation strategies. For example, what happens if 10% of the population masks versus 90% of the population? Predicting how the disease will spread based on gradual reopening of our society can help policymakers understand what effects their decisions will have on complex social webs of individuals. Here's a view of the internal Hopkins SEIRD model. It's one of the more sophisticated models in the category. It doesn't mean that it's better. Our model subdivides populations into much smaller groups. It's highly specific to the population that we manage. So we can start to get at some of the ways that this thing is differing by patient profile. I will be the first person to say that more sophisticated doesn't always mean better. Our model is highly calibrated, again, for the communities surrounding Hopkins medicine. But there are many, in some cases, vastly simpler models that are as accurate at the population level. A critical lesson in the course of the pandemic has been the primacy of the person. It was people and groups of people who got and spread COVID-19, not entire populations. And the burden of this virus has not been equally distributed across the population. Here we see state of Maryland data. Medicaid managed care organizations had far higher positive test rates in spite of being in lower age bands. Now, conventional wisdom held that age is a major predictor of infection. So we would have expected to see higher infection rates in Medicare rather than Medicaid. We heard a lot about how being in a high-risk cohort like older folks is a huge risk factor for both infection and severity. It turns out that one of the highest risk factors for infection is poverty. This plays out along racial lines too. Black Marylanders had a higher likelihood of testing positive. Note that this chart doesn't control for the fact that Blacks make up less than 30% of Maryland's population. We see it again with Hispanic Marylanders. There's a 50% positive test rate among a group that makes up less than 10% of the population. The correlative implication here is that minorities, primarily Blacks and Hispanics, are disproportionately affected by the disease, as well as exacerbating comorbidities that lead to more severe infections. It's up to our policymakers and health experts to devise solutions that recognize and mitigate this fact, ensuring a healthy future for all. Now, this is one of the ways that we as data people earn the ire, in some cases, of the general population, and sometimes we deserve it. The bar chart here on the left shows the absolute numbers of tested positive and hospitalized COVID patients, broken out by race cohort. A quick visual assessment makes it seem like the Black experience isn't all that different than the white experience. In fact, that's not really true at all. Again, Black Marylanders make up less than 30% of the population, yet 26% of their tests were positive, and their testing rates are a third less than white Marylanders. They're less likely to get tested, in spite of them having higher case counts proportionally. So again, we may be tempted to look at these yellow lines here, the hospitalization rates, and think that the rates of hospitalization are roughly equal across race cohorts, right? Well, wrong. When adjusted for population proportionality, it's clear that not only are minorities acquiring the virus at an alarming rate, they're being hospitalized more, indicating a higher severity, and they're dying at higher rates too. There are many structural reasons here: inaccess to good healthcare, reliance on public transportation, higher likelihood of being an essential worker or unemployed, higher rates of major comorbidities among minorities, all lead to those communities shouldering a disproportionately higher disease burden than other groups. Once we've done all our predictions and have considered the most vulnerable populations, relaying trustworthy information to the public comes next. Another lesson that has become clear over the course of the pandemic is that visualizations have the power to incite fear just as much as they have the potential to inform. We saw how poorly thought out or confusing visualizations and graphics can drive complacency on the one hand, or even conspiratorial ideation on the other. There were some iconic visualizations that came to the fore, particularly early on, and they entered our common discourse precisely because of their easy interpretability and clear messaging. Remember flatten the curve, anyone? Similarly, rolling transmission rates, like the one on the right, are now commonplace as we seek to map the tangible effects of policy decisions, like reopening, to the effective rate of transmission within populations. This was a popular talking point early on, and it effectively led to the erroneous comparison between COVID and influenza, seasonal flu. First, note that this graphic was put together in late April. The pandemic was just unfolding. It's impossible to know at this point how many people will be infected or killed annually. The takeaway for many was, well, according to this, COVID's not that bad. Clearly, it's all blown out of proportion. That narrative thread has persisted through to the current anti-masker movement, for example. The other part of the story, however, was this. The takeaway was supposed to be that COVID is way more mortal than the flu, so quarantine, wear a mask. But lots of people missed that latter part of the message or couldn't make the connection between the two charts. It's important to remember that a not insignificant portion of the general population are neither data savvy nor mathematically inclined. So what may seem obvious to us as the data science community might not necessarily be so to others. We saw egregious examples of visual manipulation along the y-axis. Take a look at the graphic on the right. This was shown on Argentinian television. The Argentine testing rate, the blue bar, isn't all that different from the US bar. We're doing okay, was kind of the message that was drawn. However, even though the blue bar is just about 20% shorter than the US bar, the blue bar represents 330 tests per million, while the US bar represents 7,000 tests per million. If corrected for proportionality, it would look like the chart on the right. Even more incredible, however, was when we saw the elusive x-axis manipulation in the wild. This is a rare beast, truly, may it stay that way. This is a county comparison from Georgia. It seems to be showing that over time, Georgia's most populous counties are decreasing in disease burden to the point where it's basically wiped out by May 9th. But take another look at the x-axis. The dates are a bit jumbled, don't you think? April 29th goes to May 1st, goes to April 30th, goes to May 4th. If we listed the dates in numerical order, it would look like this. April 26th is following behind May 7th. Why? These visualizations underscore the ways in which certain government agencies or their spokespeople open themselves up to criticisms of politicization of the pandemic, rather than presenting data as it really exists through as impartial a lens as possible. There were unsettling accounts of not entirely accurate or at least highly non-standard information being shared on social media and in news networks. This speaks to the responsibility in the data community to uphold a shared standard of integrity and responsibility in reporting and analysis. We will also need to take stock, once this is all over, of some of the measures that were employed to deal with the pandemic. Yes, in times of emergency, tracking infected people by using their cell phone data was absolutely the right thing to do. But we need to also acknowledge the limitations and possible threats to privacy, equality, and personal liberties by implementing the appropriate safeguards on this tech now before we need to use them again. The fundamental question is what we as a society are willing to accept in order to ensure our health and safety. And what can we as the data science community do to raise our societal health while minimizing the need for invasive data collection? This is particularly true for those in marginalized communities who are both more susceptible to infection in the first place, but also more susceptible to misuse of mass surveillance systems. If I have one request, it's that all of us, data scientists or not, public health figures or not, remember that behind these predictions are human lives, real people who are suffering, who are afraid for themselves or their loved ones, who have been affected by the downstream ramifications, some of them economic, of this disease. It's all too easy to calculate a mortality curve that predicts that it probably won't happen to me. It's another thing entirely to recognize that what this model is telling us is that it probably will happen to your aged parents, immunocompromised friends and neighbors, or other family members. Our policy and public health responses must take into account the very real health, including the mental health burden that this period has produced, and attempt to balance the calculated risk of reopening without a treatment or vaccine with a toll it will take on the American people, some of whom we ourselves will know. Thank you so much. Please stay in touch.